I've been here now for a couple of years, and I'm very keen to try and get this sort of procedure going in the northeast of England. And the facilities we had actually in Leicester was second to none, really. You know, some of the best facilities in Europe. I managed to get a big research grant to build a laboratory to isolate these cells, and unfortunately we don't have that facility in Newcastle, but we're trying to sort of overcome those hurdles to try and get this program started. So I'll just talk to you a bit about sort of islet auto-transplantation for diabetes. Here we go, let's see if I can get this working. Yeah, so chronic pancreatitis, it's a very difficult illness to treat, really, and there aren't that many people in the country who have an interest with it. It's partly because, you know, the patients really have a lot of problems going on, really, and one of the main symptoms that they have is chronic pain, and it's a very difficult illness to treat, and a lot of patients get told, you know, you need to take some painkillers, and really it's a specialist subject in itself. There are lots and lots of causes of chronic pancreatitis, but the most common cause is alcohol. And it's unfortunate in that some people can drink, you know, 1 pint of beer and it causes pancreatitis. Others may have 5 pints or 10 pints and they don't suffer from pancreatitis. And really nobody knows, you know, what causes alcohol to cause this disease, but it can be a vicious cycle. Once you have one episode of pancreatitis, it can then lead on to multiple episodes of pancreatitis, and it can eventually destroy the pancreas. Certainly in Europe it seems to be about 5 to 10 cases per 100,000. There are little pockets of pancreatitis around the country, and again there seem to be quite a lot in Leicester and also in the northeast of England, and Mr. Charnley has spent most of his life treating patients with pancreatitis. He's done a very good job. So what is the management of a patient with pancreatitis? Well, in medicine we say, well, there's conservative treatments where you can have painkillers, nerve blocks to try and dull the sensation of pain by dividing the nerves that supply the pancreas. You can take special dietary supplements that increase the ability of the pancreas to recover from an injury, and obviously one of the other important causes is actually to remove alcohol and try and stop drinking. Surgery is also a treatment, but again it's not necessarily a curative treatment, because patients with pancreatitis can have surgery where we remove all of the pancreas, and about 20 or 30% of patients will be no better off, so they still have pain. The reasons for surgery really is if you get swelling of the head of the pancreas, which will block the stomach so that patients may experience vomiting. That's obviously a time to intervene to try and allow the stomach to pass through the intestine. You can also get these cysts in the pancreas, which also cause blockages to the bowel. And you can also get duct stenosis. That means narrowing of the pancreatic duct. I always describe the pancreas like a leaf, in that it has a main stem and lots of side branches, and if you imagine the main stem getting a narrowing, then that will cause pain when the pancreas is stimulated. And in those situations, surgery can be useful to try and correct that, and that is quite specialised and complex surgery. So what sort of treatments can you offer? Well, if the duct of the pancreas is quite large because it's got a narrowing, so if you have a narrowing, the other part of the duct will swell to try and overcome that narrowing. You can actually divide the pancreas gland in half and open up the duct, and then you can bring up a loop of small bowel and stitch it to the dilated duct so that the pancreas secretions will go down into the intestine through a different route, and that works quite well. And again, there's not many surgeons in the country who are particularly interested in that, but Mr. Charnley has an interest and has one of the largest series in the world with that procedure. So this is just a diagram to show you what the operation is. So here's the pancreas. You imagine a main branch and then a main stem with side branches. Then you basically, here you can see the main stem of the leaf, and there's side branches that are dilated, so that gland's obstructed. So if you actually fillet the gland, and then you can bring up a loop of small bowel and stitch it to the side. So that's one operation that you could have to treat pancreatitis. Another particular operation you could have, if the duct is dilated in one part of the gland, in the head, there's a head, body and tail, then you could just core out the head of the pancreas, and then you can just bring up another loop out of the pancreas to the head. So this is a more minor operation, and this was popularised in Germany. There's not too many people in the UK who do that particular type of operation. Then there's a Fry's procedure, which is slightly different in that you core out the head of the pancreas and you try and relieve obstruction of the biliary tube here. The biliary tube goes through part of the pancreas, and if you have a swelling of the head of the pancreas due to pancreatitis, then you get biliary obstruction. The bile duct dilates, and then the bile, instead of going down into the intestine because of the blockage at the lower end, it's absorbed in the bloodstream and makes people become jaundiced. So there's different classifications of duct surgery. There's large duct obstruction, and in those situations it's a good idea to try and bring up a loop of bowel onto the duct. When the ducts are large, it's easy to slice the pancreas in half because it's easy to see. But the big problem is when you have a small duct, so you have pancreatitis with a small duct, then it's not so easy because it makes it difficult to do the surgery to stitch the bowel onto the small duct. So in those situations it might be best just to, resect the pancreas, remove it, cut it out. But the problem is with that is obviously the pancreas has two functions. It produces proteins which help digest the food in your diet, but it also secretes insulin, which is vital because it controls the body's blood levels of glucose. So diabetic patients don't produce enough insulin and they have to inject insulin every single day. So one of the problems with patients who have chronic pancreatitis is if you remove parts of the gland, it increases the risk of developing diabetes, particularly if pancreatitis continues and it damages the islet cells, which can be prone to damage. So you can resect parts of the pancreas, or you could actually resect all of the pancreas, which is called a total pancreatectomy. But until about 20 years ago, if you removed all the pancreas, the patient would become diabetic. Then there's a risk of maybe heart attacks later on in life, strokes, and sort of furring up the arteries, ischemic heart disease, and that can be a problem. So which operation do you do for pancreatitis? There are many different operations you can have, and really my main interest is resection of the pancreas, removing all or part of the pancreas, whereas my colleague Mr. Charnley has more of an interest in drainage procedures. So between us we actually complement each other in that we offer the full, potentially could offer the full service of surgery for patients with pancreatitis, and certainly in the UK I don't think any other unit in the country would be able to sort of match that. So this is just to say another particular type of operation. This is called a pancreaticoduodenectomy. One of the problems with pancreatic surgery is the pancreas is stuck to the duodenum, which is the outflow of the stomach. And that makes the surgery a bit complicated, and there's lots of other structures around the head of the pancreas, such as the portal vein, which is the main vein that supplies the liver, and also the hepatic artery. They're all in quite close vicinity of the pancreas, and sometimes it makes the surgery quite difficult. The problem is with this sort of operation, where you remove part of the head and you do this complicated replumbing, it doesn't solve the problem. If there's pancreatitis in the part that you leave in, the patient will still get pain. And really this is probably not a very durable operation in the long term. It might cure the problem for a start, but eventually things may deteriorate, and it's partly because you're leaving some of the pancreas inside. When you perform pancreatitis surgery, it's often tailor-made to the parts of the pancreas that's affected, because not all the pancreas can be affected. It may be just the head or the body or the tail. Not necessarily all of it, but it can be in some certain circumstances. I'm not going to show you that particular side, it's quite complicated, not very particularly interested. But this is another operation. This is my main interest, which is total pancreatectomy. It's a bit more of a complicated operation, but you actually take the whole pancreas out. So my rationale is, well, if you've got pancreatitis and inflammation of the pancreas, then the best thing is to take it all out. But the problem is it makes the patient diabetic, which is not so good. But if you could avoid the patient becoming diabetic, then that may be the best operation to do. It's certainly a controversial operation. Well, it has been in this country really until you could prevent diabetes, maybe with cell transplant. Another operation would be to remove the whole pancreas and give someone a new pancreas. That's called a pancreas transplant, but that's a very complicated operation. We do that here at the Freeman Hospital, which I do, but the problem is that donors are in short supply, and there are risks to it. Patients can die having pancreas transplants, and it's probably not the right situation to take a pancreas out and then put a different pancreas in from another organ donor. So this is just to highlight the problem with taking out the whole pancreas. It's a major operation, and it is a big operation. It's very different to removing part of the pancreas. And again, people can get complications after the surgery. and they can mean the patient may stay in hospital for quite some time. The average stay is about 2 weeks for a pancreatectomy. One of the problems is, if a patient is already diabetic, then that makes it more favourable, because there's no sort of need to try and reverse diabetes. The patient's already diabetic and they're injecting insulin anyway. So in those cases it may be the best operation. Really the only indication for pancreatectomy is if you can prevent diabetes with a transplant, or if you could actually, if a partial resection has perhaps failed. It also gives adequate pain relief, and I would say about 70% of patients who have the whole pancreas removed generally do get pancreatitis. This is just to show you the largest series reported in the UK. This was a paper that was published actually in sort of the late 1980s. And you can see that the largest single centre report of removing all the pancreas is only 83 patients, and you can see that's not a very big series, and that's because it's not a very popular operation. In this report here, they didn't put the islet cells back in, or they didn't try to treat diabetes. One of the problems is if you remove the whole of the pancreas, then basically the patient's diabetes is difficult to manage, in that they have absolutely no insulin whatsoever. So they get major swings in their diabetes, and their blood sugars vary quite a lot. So that's why it's not a popular operation really, or hasn't been in the past, because A, it's a complicated operation. A lot of surgeons don't do it very often, and also it makes the patients diabetic. But nowadays we may be able to overcome that. This is just to show you that a small number of patients may not make it out of hospital, and patients do die from this type of surgery. I'll just point out that whilst I was in Leicester in the series that we developed with the islet cell transplants, every patient got out of hospital. This is just to show you a study that was done in the Mayo Clinic in America, which I've been very fortunate enough to visit. It's one of the most famous hospitals in the United States, and it relies heavily on philanthropy to fund its program, but it's a very academic and research orientated hospital. And they looked at about 100 patients who had a total pancreatectomy, and they looked at the patient's quality of life. So were you basically better off after having all of your pancreas removed, or were you worse off? And they compared them to other diabetic patients, and there didn't seem to be any difference. So they did actually get a reasonable quality of life after having their pancreas removed. So now the trend is perhaps, well, okay, before the results weren't so good, but now the results are a bit better. Patients actually may do better if they have the whole of their pancreas removed. So this is just to also say that pancreatitis is a progressive inflammatory disease, and unless you actually remove the stimulus that causes it, it probably may continue. So therefore my rationale is, well, perhaps you should have it all removed if it's a continual process. But the object of the exercise is to try and treat it before it becomes too well established and before patients develop diabetes, because if they do develop diabetes, you can't then put the islet cells back because they're already damaged. So you want to try and intervene early. But then of course the problem is other surgeons around the country perhaps say, well, if they're not diabetic, the disease is not severe enough, and perhaps we shouldn't be doing the operation in the first place. But I think this is something that we should be doing more often. So this is basically how the process works. So you have a patient with pancreatitis who you remove all the pancreas. The patient is not diabetic, a reasonable secretion of insulin. And then what you do is you take the pancreas to the laboratory and you isolate the little islet cells that produce insulin. You don't use a syringe, but you infuse the islet cells at the time of the surgery up into the portal vein, and they embolyse in the liver. So they settle in the little veins draining into the liver, and then they secrete insulin relatively normally. So the patients then don't require insulin injections. But I have to say, it doesn't work all the time, and it really depends, as you can imagine, on how many islet cells you actually get out of the pancreas. There's about up to 3 million islet cells in a pancreas, and to prevent diabetes you need to probably give a patient in the region of about 200,000 to 300,000 islet cells. So you think, well, hang on, you should be able to get 300,000 out of a pancreas that has 300 million, but the problem is you don't know really how many are injured before you take the pancreas out. There may be a lot less, we don't know. So One of the things that I'm doing at the moment in Newcastle is I'm actually working in close collaboration with the diabetes doctors at the university, and we're developing a test that will hopefully predict how many number of islet cells are in the patient's pancreas before we actually go and try and isolate the cells, and that's a simple blood test that you can do. So if you, in simple terms, if you have a patient who secretes lots of insulin, you would think they have a lot of islet cells, and then it may be worth isolating the islets and putting them back. This is just to show you actually that an islet cell is an organelle. It's like a liver, it's like a kidney, it's its own organ, and it has its own blood supply, has its own nerve supply, and it's contained of many cells. So an islet cell is made up of lots of different cells. You have beta cells, which secrete insulin. Then you have alpha cells, delta cells, has its own artery, own nerve supply, and also its nerves are up here so that it's stimulated to produce insulin. So it's quite unique. People just think they're just cells, but they're actually not. They're like a kidney, and they're like a proper organ. So this is just to show you what would happen if you had an islet transplant. Okay, so this is perhaps someone who's had their pancreas removed. And also you can give islet cells in patients who have kidney failure. So these are patients who have developed kidney failure due to diabetes. So patients can have islet cells that are not their own. Okay, so that's what we call an allotransplant. And I don't know whether anybody's heard about a series of transplants that's been done in Canada, in Edmonton, but this is one of an Edmonton patient. So before the islet cell transplant, the patient had massive swings in blood glucose because they're diabetic, and then you give them islet cell transplant into the portal vein. This is a patient with kidney failure, and you'll see their glucose is much better controlled and it's virtually normal. So this is just to show over 24 hours an islet cell that's transplanted can have a pulsatile insulin secretion. So it's not like having an insulin injection where you perhaps have an insulin injection maybe 3-4 times a day where you get swings in blood glucose and insulin. With a transplant, there's minute, intricate physiological control, minute-to-minute variation as the blood glucose changes. So this keeps it more or less to zero. This is with insulin, it's all over the place with injection. So I want to try and aim, the better blood glucose control, the better it is for the patient and less risk of developing complications in early life. So this is the first publication that ever came out of the UK. This is one I wrote in 2001 with islet autotransplants for patients who had chronic pancreatitis. And we started the program in 1995, and it's still the largest program in Europe, and it's now actually the third largest series in the world. We've been overtaken by Cincinnati, so we're hoping to start this in Newcastle, but it takes a lot of time and a lot of effort, a lot of funding, and it's not just one person, it involves lots of different people, all experts in their own particular area. Diabetes, pancreas surgery, people in the laboratory who are experts in cell isolation, because you have to take the cells out of the pancreas, which is not easy to do, as you'll see. So this is basically the operation that we do. Here you'll see the stomach, here's the pancreas, and we take out a little bit of duodenum around the pancreatic head. When we first started doing this in Leicester, we tried to leave the duodenum because it'd be more physiological and there'd be less joins in the surgery. But the problem was there's a little artery that goes round the side of the pancreas, and that is easily to damage. And then the bowel can sort of go black and die, and that can cause a problem. So we don't do that now. We tend to take out the part of the duodenum, and this is how we transplant pancreas now. Whenever I do a pancreas transplant, I always put the duodenum in with the pancreas because it's a lot safer to do. So this is just to show you, we put the islet cells up the portal vein like an injection, and the islet cells lodge and live in the veins that drain the liver, and then they revascularise from the liver. So little blood vessels grow into the islet cells to revascularise it, to give it oxygen, to give it a new blood supply. And it's quite unique. I can tell you that probably the most famous person came from St. Louis, who worked on islet cell transplants for about 40 years and only recently died, and he devoted his life to this and was very passionate about it, and I think he's transplanted islets in every single place you can imagine, including the spleen, for example, the bowel, even injecting it back into the pancreas. But it seems that the liver is probably the best site, so there are many places that we've tried to do this. So the workup actually for this type of procedure is quite lengthy. you have to make sure that you're doing it for the right patients. And one of the things about pancreatitis, it can ruin patients' quality of life. And having this operation may change their life if it's suitable. So it involves physicians, gastroenterologists, diabetic doctors, psychologists, pain specialists, all have to give the all clear to say, yes, I think this is the operation of choice, because it's difficult when you start a procedure in the United Kingdom, for example, and lots of other centres don't do it, then a lot of questions are asked whether it is the right thing to do, but it's really should only be done in places that have expertise to do it. It's something you can't really just start off because it is quite complex and complicated. This is just to show you what a normal pancreas looks like. If I'm just trying to, you can imagine there's a main stem with lots of little side branches. So this is from a pancreas that was actually, ready for transplantation, a whole pancreas. And this is a pancreas that has suffered chronic pancreatitis, lots of inflammation, healing and tissue repair. And it's full of proteins called collagen, which makes it fibrose, and it strangulates the islet cells so they don't work. So you can see the usual pancreas is nice and yellow, but this one's very damaged, and you can see why it causes so much pain, because of the inflammation that's going on. So we basically take the pancreas out of the patient during the operation, and then we put it in a bag, and the pancreas goes off to the islet cell laboratory. This is how we did it in Leicester. So what I sort of became involved really towards the end of my medical training. Before I was trained to be a surgeon, I got particularly interested in isolating the islet cells, and then as I went on in my career I actually was at the other end of the spectrum doing the operation. So I've sort of been involved in all aspects. This is the islet cell laboratory that I built in Leicester. We got a massive grant from Diabetes UK to fund this laboratory to continue the work on islet cell transplants, but I was sort of lured to the north east of England really to come and work with Mr. Charney and Derek Manus, and I've had to leave all that behind, but I don't see any reason why we can't get a lab like this in Newcastle if we carry on the good work. So this is just to show you, if you take look at a pancreas under the microscope, here you'll see what a normal pancreas should look like. These are the islet cells here. This is normal pancreatic tissue, this is a vein. Okay, and all these little cells here are the beta cells that you can see that secrete insulin. This is what a chronic pancreatitis looks like. You can't, it doesn't look anything like what a normal pancreas should look like. The islets have been destroyed, and there's just these worlds of protein and fibrin that have replaced all the pancreatic tissue. So you can see why patients become diabetic and also experience pain. There's tiny, tiny nerves in the pancreas here that have been strangulated because of this tissue, and when they're strangulated they tend to cause pain. So this is just to show you, this is a normal pancreas here, nice yellow tissue. Here's the main stem, the main duct of the pancreas. This is a pancreatitic pancreas with chronic pancreatitis. You'll see that the yellow tissue, soft tissue, has been replaced by quite hard, thickened tissue. So this is a chronic pancreatitis. And then place a little cannula down through the main stem, ready for islet isolation. So I'll just talk you through the process of isolating the islet. So what you have to do is, here's your pancreas that's been removed. This one's not so bad. This is relatively sort of, I would say, moderate looking pancreas. That's mild, moderate, severe. And to get the islet cells out of the pancreas, you have to digest all the proteins around the coating of the islet cell. And you do that by injecting a substance called collagenase, because the protein around the islet is called collagen. So you inject an enzyme called collagenase that breaks down all the proteins. The pancreas then swells. The collagenase goes down the duct and it infiltrates around the area of the islet, and then it splits the islets away from the proteins, away from the collagen. In the sort of early 90s, the collagenase wasn't very purified, so it looked black, but now we use a purified collagenase which has less impurities in it. The collagenase, I don't want to put anybody off, but it's manufactured, it used to be manufactured from a bacterium, but now it's a more purified sample, so the actual islet isolation is more controlled and more safe. And it's also very expensive. It's about £800 for a bottle of collagenase just to digest the pancreas. So this is the kit that we use. It looks like some funny contraption perhaps, but this has been years before this was sort of the best method to isolate the islet cells. So here's the pancreas. you inject carefully the collagen, the collagenase, down into the main pancreatic duct. And the reason it's on a sieve is because once the collagenase leaks out of the pancreas, it's then recirculated and injected back in. The process is also helped because the other part of the function of the pancreas is that it produces enzymes. Patients who have pancreatitis, they can digest their own pancreas, so the enzymes in the pancreas become activated as well, which helps cause the islet cells to be isolated in the digestion of the pancreas. So we then put the pancreas in a little chamber called a Ricordi chamber. Okay, this was developed by a chap called Camillo Ricordi, who went to work with the chap in St. Louis who I was talking about, and now he's a professor of surgery in Miami, and he's Italian. Here you have some still spheres with a piece of mesh that's about a very tiny mesh, which the islet cells fall through. So you put the pancreas in with the collagenase, and then you gently agitate the chamber, and the steel spheres crush the pancreas as it digests. You then basically take samples from the bottom of the chamber here. Okay, you stain this with a substance called dithizone, and basically the dithizone chelates with the zinc molecule within insulin and stains the islet cells red. So if I can just show you here, this is the acinar tissue that's yellow. So this is the yellow pancreas that you see on the pictures. And here you can see the collagenase has cleaved, has separated the acinar tissue from this islet. So now this islet cell is totally free of all its surrounding tissue. Sometimes though, the islets stay embedded, and it's very difficult to get these tiny islets out. So this is what I'm saying, when you have maybe a pancreas that has 300 islet cells in it, 3 million, sorry, you can see that maybe trying to get 300,000 out is quite tricky because it doesn't work every single time. And it's something to do with actually what the pancreas itself is like. Does it have lots of enzymes that help digest itself? So you can see this is what we're after, single islet cells, not the acinar yellow tissue. And this is what we're left with. Here you can see about 30 mils of a digested pancreas, and that's at the end of about an hour going through this process here. So here your islet cells in here mixed up with some acinar tissue. Some of the islets in here will be totally separated. So then we need to get the islet cells away from that yellow tissue, and the first way that was done was really in a test tube. Now, although I'm a surgeon, I've probably got the hand-eye coordination to pick out all the islet cells from the tissue. I certainly don't have the time or the patience to pick out 250,000. So we needed to develop a way that would do this on large scale. So this is a machine called a co-processor that was developed to separate bone marrow cells for people who have bone marrow transplants. So we modified it by using it to isolate islet cells. So here in these two tubes here is what's called a density gradient. You put a density gradient on this machine. This basically is a density gradient in a test tube. Okay, you have high density fluid at the bottom and low density fluid at the top. You then spin it on a centrifuge and the gradient equilibrates all through the test tube. And one of the unique things about an islet cell is that they're less dense than the yellow cells that are in the pancreas. So if you put them on a density gradient and spin them round, and the islet cells are totally devoid of that yellow tissue around the islet cell, then eventually the islet cells after a couple of minutes will rise out of that tissue and come to rest at their isodense point in the gradient. So if you have at the bottom of the high gradient, you'll have all the yellow tissue because it's heavy, whereas the islet cells will creep out of that on the gradient and come to lie at rest away from the tissue that you don't want. So then you'll have a nice separation of the islet cells. So you can see it's quite technically challenging to do this. So if you imagine this is the test tube, this is the top of the test tube, and this is the bottom. Here you'll see all the islet cells that have been cleaved and come to rest in the middle of the gradient. And you put all these fractions together in one little tube, and they will be the cells that are transplanted. The yellow cells here, these are the cells that are discarded. We don't want those because they don't produce insulin. They produce the enzymes that help digest your food. But you can have supplements to treat that, such as creon. So this is just to show you that the process does work. And here I'm looking under the microscope at these samples from these fractions to decide which ones to pull together for a transplant. So obviously you can see you'd want fractions probably 2, 3, 4, 5, 6, 7, 8, 9 probably for a transplant. Put them together and then inject them in the patient. So this is just to show you that the 40 patients that were done in Leicester over the last, well, from 1995 really to 2002 or 3, I would say. Every single patient had pain, half and half were females. The cause of the pancreatitis was not known in a lot of our patients. Half the patients had alcoholic toxicity to the pancreas. Some had anatomical anomalies to the duct of the pancreas. And some had developed acute pancreatitis that was very severe and was recurrent. There's also a family history of pancreatitis as well. So I hope you don't mind, but I'm going to show you a few diagrams of operations. So this is just to show you how the islet cells are in the syringe and they're just injected into a vein. One of these little veins goes up into the liver. Here's the liver, you can just see it here. And we inject the islet cells after the operation. So the islet cells have been removed. Sorry, the pancreas has been removed, the islets have been isolated, and the patient's having the islet cells injected. For those patients who have a kidney transplant and need an islet cell transplant, they don't have an open operation. They just have an injection, like a blood transfusion. It can be done as a day case. So in years to come, we hope to treat diabetes, not with insulin, but they come in and have a cell transplant. But that relies on getting cells from an organ donor. But one of the other things that I'm particularly interested in is trying to grow up islet cells from stem cells. So this is just to show you how the islets are prepared. In the olden days we used to use a syringe, but now it's all done in a specialist laboratory, and the islet cells are lying in this little fluid here, and they're just transplanted like a blood transfusion. The largest series in the world is being performed in Minnesota, where they've done about 300 transplants run by a chap called Professor Sutherland. And this is actually, I've been fortunate enough to visit Minnesota on 2 occasions, spending quite a long time sort of learning some of the other techniques involved and talking to Professor Sutherland about our experiences. And this is a transplant that I was involved in America, in Minnesota. They probably do about 1 a week in Minnesota, so they do quite a lot. We also tried injecting the islet cells into the spleen, so this is the spleen, but that's probably not the best sign. I still think the liver is the best sign to have a transplant. One of the problems is that when you inject islet cells that are still inflamed, and if there's a lot of contaminating tissue, you can actually clot one of the vessels to the liver. Nowadays though, with the purified enzymes that we use, the purified collagenase, that seems to be less of a problem, and certainly you can have medications to thin out the blood to prevent that happening, so that it's more of a successful procedure. This is just to show you some figures about auto-transplants. You can see the weight of a pancreas. I don't know whether anybody can understand this, but the average weight of a pancreas is about 70 grams. So they're not that heavy and they're not that large. This is just to show you that the actual total number of islets that in our series was only 130,000. That's in Leicester. Now we may think, well, that's not a lot. Well, part of the problem is, I was trying to explain that one of the difficulties is knowing how many islet cells are actually in the pancreas before it's all been damaged. And in the early days when we started, we didn't really know how to sort of measure the number of islets that remained in the pancreas before you took it out. But now there are some sophisticated tests we're trying to develop at Newcastle to try and only do this procedure in patients who will not develop diabetes afterwards. So patients who will have good volumes of islets that are isolated. Really, the number of islets that you need to prevent diabetes is probably about 3,000 per kilogram per patient. So you only need 3,000. So obviously the smaller you are, the less you weigh, the more chance, if you needed this operation, you would of preventing diabetes. You can see that the operation is quite long. It can take up to 7 hours, and this is because part of the operation is removing the pancreas, which takes a couple of hours. Then the pancreas has to go to the laboratory, which we hope to have in Newcastle one day, and it takes about 3 hours to isolate the islet cells. During that time, there's another surgeon plumbing all the small bowel back together, because we have to remove part of the duodenum. Now, by the time that's finished, then the islet cells are ready to transplant back into the patient. So it is quite a long day, but it certainly is worth it at the end if you can prevent diabetes. Patients only need maybe a 1-night stay in hospital, and the total stays may be about 3 weeks, and this is because it is a big operation. But in the early days in Leicester, some of our patients don't come off insulin straight away, because if you think about it, the islet cells need time to develop a blood supply from the liver, and that can take about 2 weeks before they completely revascularise. So patients obviously sometimes during this 3 weeks have to learn to inject insulin, because obviously they've never injected insulin to treat their diabetes before. So that is quite important, but eventually as time goes on and the islets make their home in the liver, then gradually they secrete more insulin, and gradually the insulin dose is reduced and they can go home and hopefully after about 6 months don't need any insulin. This is just to show you some of the results, and you'll see that the blood glucose levels in some of our patients were slightly higher than normal non-diabetics or chronic pancreatitis patients. So these are patients who have got chronic pancreatitis with no diabetes, and these are the cell transplant patients. You'll still see that although they may be not on insulin, they still have higher blood sugars compared to normal patients, and this is because the number of islet cells is probably not enough that we're transplanting. But if we can develop more tests to try and identify those patients that can secrete a lot of insulin, they may do a lot better. So it's not surprising that even now, probably about a third of patients will not develop insulin independence, and they will require insulin injections. About a third seem to be maybe need insulin and maybe sometimes don't need insulin, and then there's a third who do well straight away, don't need any insulin. There's also about a third of patients who may not get pain relief as well, but I think now, this is about 5 years old, this stage, and I think I can certainly improve on this by being a bit more carefully selecting the patients. And also another important point is the islet isolation process has improved dramatically over the last 5 years. So this is just to show you that patients who have graft function, certainly in the city, before I left to come to Newcastle, we had patients who had quite a long time out with good insulin function. And there is a patient in America that's been off insulin for 17 years after this procedure, so that patient's likely going to live for a long time without any insulin. So these are just some of our early patients. These are in nearly 15 years ago, and it's just to show you the patient numbers here in this column and how long they were off insulin. And really, if you think about it, to give a cell transplant to someone in the liver, to keep them off insulin maybe for nearly 3 years is quite an achievement, but it was in the early 90s because it was such a difficult thing to do. But now the process has been improved a lot. I think we could expect a lot better results. This is just to show you the important thing is about the number of islets. Although this is not significant, those patients who have basically higher number of islets transplanted generally become insulin independent, whereas those that have lower numbers tend to need insulin. So really you want to aim for about 6,000 to 5,000 islet equivalents per kilogram, but 3,000 should be enough to develop insulin independence. So in that series in Leicester, about half the patients that we transplanted did come off insulin at some point. And we did have 4 who were off insulin for 3 years. And I think the longest currently patient, as far as I know, is about 8 years. So that's quite a long time. One of the problems is that you can imagine if you transplant a small number of islet cells, they're working overtime, they're chronically stimulated to produce insulin, and eventually they wear out, they burn out, and that's one of the problems. It's not like a cell transplant from one person to another, because they're the patient's own cells, so in theory they shouldn't be rejected. And what happens is over time, the islet cells, because they're chronically stimulated, they gradually show signs of burning out. This is just to show you the number of units of insulin in patients who have all their pancreas removed, i.e. they don't have a cell transplant, so they need insulin. The number of units of insulin is quite high, you'll see. But when you compare it to patients who had all their pancreas removed with a cell transplant, the number of units in insulin is a lot lower over time, because the islets in the liver are producing some insulin, but probably not enough to prevent them being completely off insulin. Now this is the important point about this process. We measure blood glucose control by doing a blood test called HbA1c, which measures the glycosylation, the glucose molecules that stick to the red blood cells, and you can work that out as a percentage. For non-diabetics, it's around sort of 6 and 7. So if you look at the patients who have an islet cell transplant with removal of their pancreas, their HbA1c level is a lot lower than those patients who have a pancreas without a transplant. And that's important because it's well known that the lower the HbA1c in diabetic patients, the less likely they are to develop complications later on in life. So therefore this makes the process, the operation that I'm talking about, a lot more attractive than in the early 80s. If you can't put the islet cells back, because the blood glucose control is very difficult, they tend to have high HbA1cs, and they may be at risk of heart disease, eye disease, or kidney disease that can affect diabetic patients. But not every diabetic suffers from complication. That's important to remember. So another thing that we looked at in Leicester was we wanted to identify, what did the patients feel like after having this operation? Did they get an improvement in their quality of life? And actually, if you look at these different questionnaires, it was shown that some of the patients actually did have a better quality of life. This is just a statistical test that you can do, and if it's less than 0.05, it means the patient were statistically better off. So it just shows that even after this big operation, even if some patients required a little bit of insulin, they still did well and felt better in themselves. And this is just to show you that one of the problems of pancreatitis surgery is pain. 16 of the first 20 that we did had very good pain relief, okay, and a lot of them were no longer required any opiate analgesia or regular analgesia like paracetamol, codeine, and they did well, but some of them still required things like codeine to treat their pain. So this is just to show you one of the other problems is that patients, because with pancreatitis, they've had pain for so many years, and they become addicted to opiate drugs such as morphine. They can be, and you can't just stop a patient's painkillers. You have to work it over gradually. And this is just to show you that as time goes on after this operation, more patients require less analgesia. So that's important. You can't expect someone to just stop their painkillers after an operation, because it does take time for them to wean off the drugs. I've just got a few slides here just to show you the world figures. I don't know, this is on a timer, unfortunately. Can we go back? It was just to show you that these are the number of transplants that were done around the world. Minnesota's now, this is an old site, they've now done over 300. And Cincinnati and then Leicester. Okay, hopefully we'll have Newcastle in here sometime, I don't know, we'll see. This is just to show you where Minnesota is. I'm just going to show you a few pictures now. This is Minnesota. It's basically the state in the US, which is called the city of Minnesota's. Minneapolis is the capital, and it's called the City of Lakes. It's very much like the Lake District. So there's about 10,000 lakes in Minnesota. Very beautiful part of America. It's near the Canadian border. So here you can see Minnesota, New York over here, Chicago, Illinois over here. So this is just to show you what Minnesota looks like, the City of Lakes here. And here's my son chasing a squirrel in the park, and this is what Minnesota looks like. They have this park called Monument Park where they sort of make these strange contraptions, which I've never quite understood, but it's a nice place to go for a walk. This is Professor Sutherland from Minnesota. He'll probably shortly be retiring, and he's been involved in islet transplantation since about the first paper I read from his work was in the early 1970s, some of these papers here. Minnesota was the first place in the world to do a pancreas transplant, so they have many, many world firsts. It's really the mecca of transplantation, and really anybody who's passionate about transplantation and pancreas surgery really should go to Minnesota, because there's just so much to learn. And it's where the world's first islet transplant was performed in the early 70s, and the world's first autograft done in 1979. So really, if it wasn't for this guy, we wouldn't even be doing this procedure, because I think it takes a lot of guts to do something new, particularly transplanting bits of pancreas into someone's liver through a vein. That probably 30 years ago they thought it was not the thing to do, but it's proven durable and certainly a treatment that should be offered. So I've just got some more slides here. This is in Minnesota. This is Professor Sutherland's data, and you'll see that the Edmonton islet cell transplant program was sort of published here in 2000, and you can see that since that time the number of autografts in patients with pancreatitis has just ballooned out of all recognition in Minnesota, and that's why he's doing nearly one a week. He's doing a heck of a lot of transplants, and he gets patients from all over the world and all over America. And again, his distribution of patients is similar in that a lot of the patients don't really have a cause of their pancreatitis. So Some of the patients have alcohol toxicity, so they're very similar to what ours are, but a lot of the cause is not known. You'll see that one of the other things is that with pancreatitis surgeries, that a lot of patients have operations because the diagnosis is wrong. They think the diagnosis is maybe due to something else, and if it's patients are not, if they don't go to centres that are experts in pancreatitis, they can have many operations to treat their pain. So one of the problems is, the surgery is difficult because patients have already had surgery, so when we come to remove the pancreas or do another type of procedure, it can be a problem. And you'll see that a lot of the patients that Professor Sutherland has, they've already had these drainage procedures to try and decompress the duct. But again, it just shows that they come to him because the duct drainage maybe hasn't worked, and they should therefore have the whole pancreas removed. This is just to show you as well that patients who have had previous surgery, you won't isolate very many islets from those patients. So this is what I'm saying, in that it's best to get the disease before it becomes too established, and perhaps remove the pancreas before the patient is rendered diabetic or has surgery somewhere else. If you get the native pancreas with no surgery, you'll isolate a lot number of islet cells, and the patients are likely to get more pain relief and also not have insulin. But if they've had previous surgery due to a drainage procedure, they're more likely to need insulin, and then you could argue, well, the operation probably may not have been the right thing to do. So here's Professor Sutherland in the operating theatre doing a pancreatectomy. Here's the pancreas. You'll see that there's a lot of blood in these swabs because the surgery can be difficult. And here's me we've just been to prepare the islet cells, and we're now going to inject them into the patient in the back. So this is just to show you some of his data from his first 112 patients. You'll see that in this series about a third will have developed won't require insulin injection at some point. 12% of his patients just require a single daily injection to control their diabetes, which is pretty good if you think diabetic patients maybe need 3 or 4 injections a day to control their blood sugar. And he's got patients, at least 30% of patients, a third out to 2 to 10 years, which is very, very good. All on about 300,000 islets, which is not that many. And one of the good things is if you can get beyond 2 years, perhaps, with no insulin, then you may be rendered, a non-diabetic for the rest of your life. This is the important thing for pancreatitis patients. Do they get adequate pain relief? You can see that nearly in 2/3 the pain resolved, so that's important. No patients have worse pain, but I must admit that does happen. And again, maybe 10 or 15% don't have any change, so they're no better off. But in general, most patients do better. I don't think we need to know. So this is just the last slide to just say that, human islet transplants in patients with pancreatitis can lead to insulin independence, but some patients may require insulin. But the key really is to try and identify those patients that will produce a lot of insulin, that we can isolate the cells and then put them back if that's the right operation for the patient. Thank you.
You did say you'd take some questions.
Oh yeah, feel
Would
free.
you like to handle that yourself?
How long does the islet live when you've took it out of the pancreas? Can you not keep trawling through the sludge for a few weeks afterwards and then inject some more into the liver?
Well, it's interesting you should say that, because what you can do, which is very sort of new, once you've isolated the islet cells in the lab there, what you're left with is the stem and branches of the pancreas with no tissue attached, so you're left with the ductal system. And what now people are doing is, if you put in the right growth factors and grow that piece of duct up, you can actually isolate stem cells, adult stem cells from that ductal system. And we hope that maybe, we could grow those into whole islets. So you could actually, do a transplant, and then maybe a year later, if you've grown up these stem cells, then put more islets back in. So that's a theoretical possibility. Another thing that's happening in the UK is that you may see on the internet, in the papers, there are lots of stem cell banks now that are being developed around the country, where babies are born and mums and dads are sort of paying for their umbilical cord blood stem cells to be preserved, i.e. they're frozen. So if you develop pancreatitis, then when the baby grows into middle age, it's in theory you could have an islet cell transplant, then you could have gradual top-ups with these umbilical cord blood stem cells if you get them to differentiate into adult islet cells. To answer your question, if an islet cell is taken out from the pancreas, you could probably leave it in culture for up to a year. So they do last for up to a year. But the problem is they become starved of oxygen, and really it varies. You wouldn't really want to have an islet cell transplant if the islets have been cultured for probably more than a week. In the early 80s, it was thought that if you take islet cells, isolate them, put them in culture, if you left them for a week, the transplant would be more successful. And this is because there's less impurities in the transplant, because the impure things have all died away. And also it was thought to lead to less rejection. I'm talking about now patients who have had an islet transplant from islets from one person into another person. So there's a rejection barrier there, and if you culture islet cells, they tend to be less prone to rejection.
I'd like to know.
Feel free to ask anything, honestly, anything.
I'd like to know one thing. How do you know, since they're obviously very small,
Yeah.
when you've got, I don't know, 300,000,
Yeah.
how do you know where you
Well,
are?
we take a sample of the tissue, and
Right.
we just basically do a count, and using dilution factors we work out how many
Right,
is in
you
the
can
total sample.
Extrapolate.
Yeah, and we use a microscope with a graticule that has a little ruler on it that's
Oh,
magnified. And then we can measure, we take a sample of say 200 islet cells, and we measure how big they are, how wide. So they may be like 150 microns, which is sort of 10 to the 9, very tiny. And then you can work out what your volume of islet tissue is. The important thing is as well to remember is an islet is sort of spherical, so you have to correlate it with sort of volume.
Yes, gosh. Extraordinary bit of technology.
I noticed on one of your charts there was like an age group of, I don't know, 50 to 61, something of that nature.
Before you finish your question, I'll answer it.
I'm too old.
The good thing about this is, okay, I'll just explain. If you have somebody who's diabetic, okay, and they're in the age group of say up to 50, and they've got severe complications with their diabetes. I'm talking about now not pancreatitis, but I'll come back to that. So these are diabetic patients who have developed diabetes in childhood, from about the age of 4, 5 or whatever, and they inject insulin daily, and then they develop problems with their eyes and their kidneys. Not everybody develops problems with their diabetes. And one of the things that we do at the Freeman Hospital that I'm particularly interested in, we can treat those patients with a whole pancreas transplant. Okay, so these are patients who their pancreas doesn't produce any insulin, that's why they have to inject it. So we would give them, if they've got kidney failure, we would give them a pancreas transplant to treat their diabetes, and the kidney to treat their kidney failure, because if a diabetic patient develops kidney failure, they may be on dialysis, and having a kidney transplant is better than dialysis, so they'd have a combined transplant, a kidney and a pancreas. Not many are done in the UK. That's a big operation, and we would only do it in someone who's probably under 50. Now, what you could do is, instead of having a whole pancreas transplant, which is a big operation, you could have an islet cell transplant, where you just simply come into hospital, we put a little wire into one of the vessels in the liver and inject islet cells like a blood transfusion. And for that, there is no age limit. And this is one of the attractions of this particular type of thing in developing islet cell transplants, is that there's no age limit. But if you have chronic pancreatitis, really the only drawback is you have to be fit enough to get over removing the pancreas. And I would do that in somebody who's in their 60s if they've got a strong heart and they're fit. Does that answer your question?
You better hurry up, Ken.
Say again?
So you better hurry up. We're getting near the back.
Well, I've only got that much left of the pancreas anyway. So.
But you might be, eventually, who knows, we may be able to give transplants to patients who who are already diabetic who have chronic pancreatitis, particularly if their diabetes is very difficult to control. And that's
I take it the rejection side is similar to, say, a liver transplant.
no. Well, with this particular scenario, there is no rejection.
Yes, I know,
Yeah,
but I couldn't do that because that bit of my pancreas
No,
is gone.
correct.
So
You've got it.
if
So
I-
if you had another person's, if there was an organ donor and a pancreas available, we
Yeah.
isolated the cells. Yes, we could give you islet cells, but you'd have to have drugs to prevent the graft being rejected.
for the rest of.
Absolutely.
So what's the balance between the two? Because you hear a lot of
they're
people have problems
correct.
with that.
You have to get that balance, but you see, the reason we do it is if you're diabetic and you've been on insulin for a long time, you can develop what's called hypoglycemic unawareness. In that when your blood sugar drops very low, usually what happens is you become shivery, you may become a bit confused, you become sweaty, and that gives you a trigger that your blood sugar's low, and then you need to get glucose somewhere, have a sweet or something, and then you feel better. But eventually, over a number of years, patients lose that awareness. So they could be driving in the car and they have hypoglycemic unawareness, and they wouldn't know they are hypoglycemic, and then they become unconscious. And then there's a risk, if they're not found, they would die. So in that situation, you can argue, well, the benefit is worth taking. The side effects from immunosuppression are worth taking if it's going to prevent the patient from dying from hypoglycemic unawareness.
Are you talking about someone who's slowly regressed into diabetes?
No, I'm talking about a patient perhaps who's had diabetes for a long, long time, a number of years, and gradually over the years their awareness...
How long? Yeah, but that can take, what, 20 years?
It might take 2 years.
Right.
It's variable. It really is variable.
Okay. I'm more interested in the transplant side. Can you
Yeah,
do
sure.
a partial transplant?
Yes, in the early days, people did do partial transplants, but actually they weren't that effective because you generally needed to put the whole pancreas in to get better results.
I only want the insulin bit.
Yeah,
I'm all right on the enzyme.
Well, exactly. So you might as well just have the cells. Exactly. So that's why we do it. You might as well just. You don't need it. You don't need the whole pancreas. The number of islet cells that make up the pancreas is about 2%.
Right.
2%. So why put the other 98% in? And the problem is with doing a pancreas whole transplant, it's a big operation and it has complications. You know, so 25% of patients will need further surgery. But with this, you don't need any surgery. You need an injection, basically. Not for chronic pancreatitis, but for diabetic patients who have problems.
You mentioned the adult stem cells and growing from the... It's like, how far on is that? Are people actually doing that?
Well, there's two types of, there's sort of 3 types of stem cells. There's embryological stem cells, where you take stem cells from the embryo. With this, there's adult stem cells, which are taken from adult tissue. And obviously there's umbilical cord blood stem cells. One of the problems is it's very difficult to coax a cell into growing down a particular cell line. So these stem cells could grow into any cell, a cell for the liver, the brain, heart, everything. And it's knowing how the body makes it become an islet cell, and that's the problem. There are lots of genes that are turned on to develop these cells into islet cells, and it's knowing the sequence of genes, how they're turned on to develop that. So you can take what has been done so far is you can take stem cells, you can make them express some of the genes that are expressed in islet cells, and they can secrete very tiny quantities of insulin. So we're sort of getting there, but I really don't think maybe in the next 10 or 25 years it will be possible to do it, but who knows?
You're saying collagens causing scar tissue on them. Is there no way of stopping the, collagen gets less as you get, you produce less as you get older?
One of the problems is with the scar tissue is the body's natural defence against injury is inflammation, and one of the integral parts of inflammation is laying down proteins and fibrosis. And if you didn't have fibrosis, then the body wouldn't heal properly, and it could lead to further problems. So that's sort of a simple way of looking at it. But it's not necessarily the sort of protein around the islet cells that strangulate it. I mean, basically things like, say, alcohol are toxic to islet cells, and it's that what destroys the islet cells. It's the actual chemical toxic injury rather than strangulating the islet cells.
in my ignorance, what is Creon supplement?
Well, the pancreas has two functions. It produces insulin, which you can inject, and then the other function it has, the insulin controls the blood sugar, and then it produces lots of proteins that help digest the food in your diet. So, like for example, it produces the proteins that digest down the fat in your diet and sugars and things. And the Creon is a tablet that is made up of all these other different proteins the pancreas secretes. So it helps patients sort of digest their food so they don't become undernourished, and prevents them having diarrhea when there's a lot of fat in the stool. So when you have your pancreas removed, you need obviously insulin from somewhere, and you need the Creon tablets to help digest the food. But one of the things about Creon is you don't have to inject it, you take it orally as a tablet. But with insulin, unfortunately, you have to inject it because oral insulin doesn't have very good what we call bioavailability, in that it's metabolized by the gut. So it works best by being injected and then going straight to the liver through the veins to work on the liver. Whereas if you took a tablet of insulin, it wouldn't work very well.
Any other questions? Well, I think it's a moment to say a big thank you. A very big thank you. It's always wonderful, isn't it, to listen to an enthusiast. To listen to somebody who's passionate about something, and somebody who's passionate about making us better. What could be more encouraging? And thank you for that. Not just for what you said tonight, but for obviously the trajectory of what you're aiming at long term. Let's hope that this laboratory gets established here